The following podcast is part of a certified educational activity titled Exchanging Ideas on How to Navigate Patient-Centric Clinical Decisions in Integration of TROP2-Targeted Therapy in Triple-Negative Breast Cancer and HR-Positive HER2-Negative Breast Cancer. Access the entire activity and complete the post-test at peerview.com/TSZ860. Downloadable slides and practice aids are also available.
Hello, and welcome to our program on exchanging ideas about how to navigate patient-centric clinical decisions in integration of TROP2-targeted therapy in triple-negative and hormone receptor-positive HER2-negative breast cancer. I'm Hope Rugo at the University of California, San Francisco's Comprehensive Cancer Center, and I'm joined by my colleague, Sarah Donahue, an advanced practice provider who works with me at UCSF. Thanks for joining me, Sarah.
Thanks for having me.
Our program today is going to talk about a few different areas. We first want to review the knowledge of the evolving clinical role and latest clinical evidence about TROP2-targeted agents in the treatment of triple-negative and hormone receptor-positive HER2-negative breast cancer. We also want to work on skills about how we integrate TROP2-targeted ADCs into treatment plans and how to appropriately select patients with TNBC and HR-positive HER2-negative breast cancer for treatment with TROP2 ADCs. We also want to discuss the patient-centric, team-based equitable care for our patients who have these disease subsets. And of course, we want to talk about management of toxicity, both prevention and targeted, focused management of developing toxicities so we can optimize care and access to treatment for our patients.
My name is Holly Hernandez. I was diagnosed with triple-negative breast cancer at the age of 35, postpartum breastfeeding a 4-month-old infant. Additionally, I was a mother of 5 and also a working mother. And so I was on my maternity leave and I just had a lot of things on my mind. I think that paying a little more attention to my body, maybe I would have recognized. But again, a lot of changes with pregnancy and breastfeeding mimic the symptoms of breast cancer. I first noticed a lump in January, February 2021, and I assumed it was clogged ducts. However, they did not end up resolving. I returned to work in March while I was continuing to breastfeed and tried some different options to relieve the clogged ducts at home. None of them were successful. Early April of 2021, I mentioned this to a good friend of mine who's also a nurse, and she convinced me that I needed to go see my primary care provider right away, in which case, thankfully, my primary care provider saw that there was an issue immediately, and a mammogram and ultrasound were scheduled for 2 days later. During that mammogram and ultrasound, they found calcifications and a lot of signs of breast cancer. And I went ahead and had a biopsy, I believe, another 2 days after that. I ended up then being diagnosed with stage 2 triple-negative breast cancer after that biopsy on April 21st of 2021. I ended up finishing chemotherapy on November 10th of 2021. And my surgery, which I had chosen a double mastectomy, happened on December 9th. After the surgery, they did find I did not achieve a PCR, and they ended up finding cancer still in the tumor in my breast. I believe it was a 5 millimeters, not very large, but they, in addition to that, found that one of my sentinel nodes did still have active cancer in it as well. And going back to the biopsy, they had biopsied that actual lymph node, which did not biopsy positive. It was negative for cancer at that point. So that kind of threw me into being actually stage 3 rather than stage 2. After that, my oncologist recommended radiation. I began that in, I believe, early February of 2022. In October of 2023, I was having shortness of breath and went to my primary care provider and learned that I had a large pleural effusion. Based on that, they did end up finding a tumor in my pleural space, which biopsied, showing that my triple-negative breast cancer had returned. Eventually, they also found metastasis to my brain. And on December 5th of 2023, I had gamma knife brain radiation for those 3 brain metastases. And the next day, December 6th of 2023, I began treatment on sacituzumab. I ended up having a infection involved with my Pleurex drain that was in my lung to drain the fluid. And in January of 2024, I did have to take a break from sacituzumab when I had a lung surgery involving a thoracotomy and lung decortication. After I healed, I began taking the sacituzumab again, and I am still on that today.
So let's talk about how we can harness TROP2 targeting antibody drug conjugate therapy in triple-negative breast cancer. So the first phase 3 trial that was done with the TROP2 ADC was the ASCENT trial, and this was based on encouraging data from a phase 1/2 study that looked at sacituzumab govitecan in patients with heavily pretreated triple-negative breast cancer. So based on that data, after the ASCENT trial had already completed accrual, there was accelerated approval of sacituzumab. Then we were able to report the data from this trial that randomized 529 patients with metastatic triple-negative breast cancer who'd received at least 2 prior chemotherapies for metastatic disease, and there was no upper limit on the number of prior therapies. The median number of lines of therapies that these patients had received were 4, somewhere between 3 or 4 in the metastatic setting. Patients were randomized 1-to-1 to receive sacituzumab govitecan, or SG, versus treatment of physician choice that included capecitabine, eribulin, vinorelbine, or gemcitabine. Of note, SG is given on day 1 and day 8 every 21-day cycle at 10 milligrams per kilogram. Stratification included the number of prior chemotherapies, the geographic region because of what therapies are available for patients in different geographic areas, and whether patients had brain metastases. And when we developed this trial, there really wasn't anything much we could do other than radiation for brain metastases, and we're still really struggling with management of brain mets in patients, particularly with triple-negative disease. So we made the decision to have the primary endpoint be progression-free survival in patients without brain mets. But we also had PFS in patients with brain metastases, with a cap on the number of patients who had controlled brain mets who were enrolled in the entire trial, and then the usual secondary endpoints were included. So this shows you the primary endpoints for the ASCENT trial, looking at progression-free and overall survival in patients who did not have brain metastases, showing this remarkable improvement in progression-free survival, even in patients who had this very heavily pretreated, really nasty cancer, triple-negative disease. Hazard ratio for PFS 0.41, and the hazard ratio for overall survival 0.51. And you can see that the medians are really a big difference, with a big difference in median overall survival from 6.9 to 11.8 months. The curves here for overall survival separated early, and as you would expect, you have a little bit of a fall off on the first scan in the progression-free survival, and then the curves separate and stay separated widely throughout. When we looked at the patients who had brain mets combined in the entire patient population, we saw similar benefit with sacituzumab, so that was really encouraging data. And then looking at the toxicity in ASCENT, we saw really the same toxicity that we'd seen in the first phase 1/2 trial. The trial required that patients have an absolute neutrophil count of at least 1.5 to start any new cycle, and an absolute neutrophil count, as we use in standard practice, of 1,000 to start at day 8 of any cycle. So what you can see is that all grade neutropenia was for sacituzumab higher than treatment of physician choice at 64%. Grade 3 or greater was 52%, about half of the patients. So that's really important. Now, encouragingly, febrile neutropenia was very low, only 6%. And I think it's avoidable by using prophylactic growth factors that we'll talk about later in patients at higher risk. But this trial did not allow prophylaxis. You could start growth factors for a cause, but you couldn't use them prophylactically for good reason because they needed to see how patients did. There's no real hepatic toxicity, very mild liver enzyme elevations with sacituzumab. The other most common toxicity is diarrhea at 65%, and 10 to 12% were grade 3. So that's an important area to focus on as well, and we'll talk about that in a little bit. Nausea was seen in about 60% of patients, but again, we were learning how to prophylax, and using a 3-drug regimen, we just don't see really much nausea. And you can see here that only 3%, even without grade prophylaxis, were grade 3 or greater. So that's encouraging. Even though patients take loperamide for diarrhea, they only had 37% low-grade constipation. And stomatitis is very low-grade, only 11%, and very little difference from treatment of physician choice. The difference there is just 5%. So that was encouraging as well. So there are a number of ongoing trials evaluating TROP2 ADCs in metastatic triple-negative breast cancer. ASCENTO-3 and ASCENTO-4 are respectively looking at sacituzumab PD-L1 negative versus positive disease. In ASCENTO-4, pembrolizumab is combined with sacituzumab, and there's very nice preclinical data that suggests that combining an ADC with a checkpoint inhibitor may be more effective based on really a synergistic reaction between the two, where you have more neoantigen exposure with the ADC that might enhance the immune effect. And you might upregulate some of the immune effector cells with the antibody drug conjugate. The TROPION-Breast02 trial is a first-line triple-negative breast cancer study that is completing accrual now. And that's looking at Dato-DXd versus investigator choice chemotherapy. These are all first-line trials. And then TROPION-Breast05, which is opening now as TROPION-Breast02 closes, is a first-line trial in patients who have PD-L1 positive disease, looking at Dato-DXd with or without durvalumab versus investigator choice chemotherapy and pembrolizumab. So I think it's Dato-DXd and Dato-DXd durvalumab, and includes both the PD-L1 positive and negative population. But the Begonia trial is a trial that's reported data already with Dato-DXd and durvalumab, showing very nice responses in the first-line setting. This is just a phase 1b/2 trial. And then there's a trial that looked at sacituzumab govitecan and atezolizumab that was presented at ESMO Breast this year, 2024, and that showed similar efficacy in a PD-L1 positive patient population treated with SACI and atezo. So really encouraging combination data. OptiTROP is looking at sacituzumab deruxtecan versus investigator choice chemotherapy, and that trial is already been presented in the at ASCO 2024 with an improvement in progression-free survival in the patients who received sacituzumab deruxtecan. Very nice data. Overall survival is early in that patient population. And then there is a planned phase 3 trial in the first-line setting looking at sacituzumab deruxtecan versus investigator choice chemotherapy. And there are some other ADCs that are being tested, with one other phase 3 trial with a TROP2 ADC that's just starting up. In early triple-negative breast cancer, there are 2 trials looking at ADCs in patients with residual disease after neoadjuvant therapy. So this is TROPION-Breast03 with datopotamab deruxtecan, and ASCENT-05 with sacituzumab govitecan, all with its respective checkpoint inhibitors. And then TROPION-Breast04 is a neoadjuvant trial looking at Dato-DXd and durvalumab for 8 cycles in triple-negative or very low ER-expressing disease. So just as before we get to our case, I think it's an interesting, area that's incredibly important for us to just think about equitable care that we can provide to all patients with breast cancer. I think it's, even in the United States, we're seeing a lot of disparities and inequities that disproportionately affect medically underserved populations. And there are a number of barriers to care. There are economic, language barriers, there are cultural issues, and there's other barriers like transportation, where people live, their medical understanding and their courage, I think, in seeking care in different places and questioning what decisions are being made and their involvement in decision making with their providers. We know that social determinants of health play a big role here, and those are some of the things that I was just mentioning. Medical literacy plays a role, and access to care in terms of where you live. There's a lot of variable quality of care. For example, are you receiving your care from somebody who only treats breast cancer, or a clinic that only treats breast cancer, or a general medical oncologist who maybe doesn't treat very much breast cancer at all, or somebody who has a focus in breast cancer? There is some implicit bias as well, and many other factors that are too broad to go through here. And if you look at the breast cancer incidence and death rates by race and ethnicity, you can see that there's a lot of variation in terms of the rates of death, actually mortality, and some differences in incidence. And if you look at the non-Hispanic white, you can see that that and non-Hispanic Black have the highest rates, but there's a disproportionate mortality between these two groups, which we really have a hard time figuring out. But definitely access to care plays a role, and different toxicities with drugs and access to care. All of these things play a role. So the diagnosis of breast cancer in Black women is lower, but Black women tend to be diagnosed at a younger age. And in young women, not in postmenopausal women, they have a higher rate of triple negative breast cancer compared to non-Hispanic white patients, and have the highest death rate. So when looking at this in detail, there's more delays in therapy, less adequate treatment. People stop treatment earlier, for example. They might receive only 1 or 2 lines of therapy versus 5 to 7 or 8 lines of therapy. And unfortunately, minority patients are significantly still underrepresented in clinical trials, which is an area that we all really need to work on. And I think it's going to require a really community-based shift in order to try and target this, not just, saying we want to enroll more patients. We really have to play a big difference. We looked at the outcomes by race in a ASCENT trial. And in the ASCENT trial, 12% of patients self-reported that race is Black, which is a really good percentage compared to many trials. Recently, we saw a trial where there was just, one patient in each arm who identified as Black. So this was, I think, a good representation, even though small compared to our population. And then if you look at the outcome in progression-free survival and overall survival, we saw the numbers are small, but very good results. So it suggests that we're really able to treat patients effectively. There was no difference in terms of the adverse events. Neutropenia was similar. And the diarrhea, hard to know whether there's diarrhea differences here, but because the numbers were so small. But I think overall, we believe that the toxicity is relatively similar. We know that there's racial differences in pharmacogenomics, so looking at metabolism of SN38 through UGT1A1, and there are many different lower incidence polymorphisms, so that work is ongoing, and we'll learn more about it later. So I think that this is encouraging data and really important for all of us when we're looking at clinical trials, that the outcomes by race appear to be equivalent when you look at the Caucasian and Black population, and there's no difference in toxicity. So, Sarah, we're very interested in overcoming disparities in breast cancer in terms of clinical trial participation. And so what are your thoughts really about how we can manage this, and, how can we really incorporate this into our clinical practices?
I think that one thing that a lot of my patients bring up, whether or not they are, Black or white, or when they're sort of have less health literacy in situations like that, is that they don't know what role a clinical trial could play to them. They don't know that it could be something that could help them when they're earlier in their disease course. Some of them think that that's a last resort of what you would get. It's something for when you've run out of all standard of care options and you are, at the end and nobody can help you. So I find that that is the most common thing that I have to correct with patients. But then I think also having, coming from a community practice, if you remember, I came from a community practice a long time ago, and I had access to university or academic type practices that were maybe 45 minutes to an hour away. And just the idea of telling a patient that they might have to travel to go do a clinical trial, I was hesitant to do that. I will say that. So I think also encouraging providers that these patients are willing, they want it. If you look at all these studies, it shows that they want to be offered those trials. They would be willing to travel if they had to. So I think that those are the two things that come to my mind.
And those are such great points. And I think that one other thing to just add in is many sponsored trials will have reimbursement for travel costs, for tolls, even for housing if people need to stay overnight for, say, pharmacokinetic blood draws, et cetera. And that it's always worthwhile to ask. And sometimes when it's not clearly stated, just asking is helpful. Some of the trials that are investigator initiated will incorporate institutional funds to try and help offset those costs as well. So I think that there are a lot of different ways to try and help. And I think, the other thing that does help a lot with patient care is team-based collaboration and so-called patient-centered care. And, working together as a team to try and provide the best care possible. I think our group does a really good job trying to do that, working with our advanced practitioners, our advanced practice providers, and our nurses, both in our triage group and infusion, as well as our experimental pharmacists and our non-experimental pharmacists as well. We have symptom management that helps us with both managing symptoms and end-of-life care. As well as a phenomenal social work group. I don't know how you feel that experience works, Sarah, and what the best interactions are.
I mean, it's always helpful to have more people helping. When you have children, they say it takes a village. When you have cancer, it does take a village. You need people that are specialized in or knowledgeable in everything in all these different areas, and it's just too much for one person. Your provider can't do all of that. Your nurse practitioner, your doctor can't do all of that. Your nurse can't. So having access to all of these groups is really, really helpful so that they can bring their expertise to helping each patient sort of get them through treatment and with the least amount of side effects possible, the least sort of pain, whether psychological or physical, that you can get patients through treatments.
Yeah, I mean, I find that our patients love that team approach. They really feel like, and we recently had the experience of a patient who passed away from her cancer. And, the family were all seeing us as an integrated group, equally important in patient care. And it made them feel surrounded by care and supported in a way that I think is so incredibly important because, a lot of our patients won't survive their cancer. We have a lot of metastatic patients in our clinic, and having that kind of support is really great, and people feel very grateful for it.
I think my advice to healthcare providers would be, first of all, to take the time with your patient. Allow them to ask the questions they need to ask to feel more comfortable with the care you're giving them and more trusting of the decisions that are made for them or that you're able to help make decisions with them rather than make the decisions for them. Being compassionate and understanding each patient's unique circumstances is also very comforting to a woman like me. I feel like after I was diagnosed, it was a very overwhelming and hurried process as far as this is what's next. We need to do this. We need to start treatment right away. And it kind of feels like you're on a crash course and there's no way to slow it down. So I think just really taking the time to tell patients to think through the decisions that they make and that there are more options than what is right in front of them. One other thing I'd like to mention is with my past as a social worker, I felt like there was a lot lacking in the social work and patient advocacy related issues with breast cancer. A lot of the resources that I found on my own. And I think that a lot of other women don't really have the knowledge of where to go to look for these things and depend on these people to provide them with the resources out there. I think one thing that's been very important for me too is the fact that my oncologist has that next step planned. It's very comforting to have the knowledge of what is going to happen if my disease progresses. And, just knowing that helps ease my anxiety. And then, just making sure that patients are aware that they have choices to make and that it's their choice, not the doctor's choice. To other patients, I want to go ahead and say a couple things. I mean, I think finding a doctor in a cancer center who provide the extra support that you need, given your unique set of circumstances, is very important. I had to travel further to get better care, but the payoff is going to be greater in the end, I believe. For me, joining a group of other women who are diagnosed with breast cancer definitely makes you feel less alone. And for a lot of women who are diagnosed young, that is a common feeling of being alone and not having people to talk to that share your emotions and share your experiences. So go out there and find a support group so that you have someone who feels the same feelings that you have. And advocate for yourself would be my last piece of advice, because there's no one out there that's going to advocate for you. You have to take the time and the information and go out there and seek knowledge about breast cancer and your specific type of breast cancer, what type of treatments are out there, and all the different options. Because at the end of the day, we make so many decisions, but being informed in those decisions is the best advice I could give another patient.
Let's talk about a case. Sarah, tell us about Emily.
Okay, so Emily is a 43-year-old Black woman. She's diagnosed with triple-negative breast cancer. It's metastatic to her lung as well as her liver. She's been previously treated with anthracycline-based chemotherapy and taxanes, as well as pembrolizumab on the KEYNOTE-522 regimen. At diagnosis of metastatic disease, she's on pembrolizumab as well as capecitabine because at the time of her surgery, there was residual disease. So at the time of diagnosis, there's no brain metastases. She has good performance status. She presents with worsening fatigue, dyspnea, and abdominal discomfort, and the imaging reveals multiple new lung nodules and liver lesions. Things to consider is that she's unemployed, she has no social support system, she lives alone, and has difficulty finding transportation to get around. So in this patient who is recently sort of gone through early stage breast cancer and recurred while on capecitabine and pembrolizumab, Dr. Rugo, what would you consider for treatment?
These are such difficult patients to treat and such bad disease, where we know that this is a situation that we can't cure the cancer. And in the ASCENT trial, patients were eligible. They had to have received one additional line of chemo, but, a lot of people weren't getting capecitabine then in the adjuvant setting. So in this situation, you had residual disease after neoadjuvant therapy, you get the capecitabine, you're recurring, you're still getting that treatment. That's really tough. And I think that, our choices really are to give sacituzumab govitecan or gemcitabine and carboplatin. But if the patient's received a taxane and carbo as part of their neoadjuvant therapy and has residual disease, I'm much more likely to choose sacituzumab govitecan here in this first-line setting, even though it's a little bit outside, we have different treatments now. We didn't have KEYNOTE-522 when we were doing the ASCENT trial. So I, in this situation, commonly use sacituzumab govitecan. And I have to say, I probably had the longest responses in this setting where I can use it in the earlier, before patients have more bone marrow issues and more resistant disease. And we talked to people about this, how we're going to manage the treatment and the need to come in twice out of every 3-week period of time. And, you have to talk to people about what they're willing to do and, their balance of, efficacy, toxicity, and impact on their, their lifestyle, quality of life, resources, etc. We've also worked at UCSF to establish a patient support fund, and are working more on this as we go forward. We have a lot of donors who are really interested in that can help with people who have children, live far, problems with transportation, help with parking, sometimes meal tickets, a lot of different things that may allow people to get optimal therapy.
I was just thinking this patient's already gone through so much and now is needing to go through more. So I feel like something may have already been in place, but maybe those supports have sort of broken down or become wary. So continuing on with supporting them as much as you can.
Well, the other thing is that, the American Cancer Society still has ways of helping patients have transportation. Sometimes, the social support system is a really big issue in people who live alone, and finding people. I called somebody's distant friend the other day to get them to take her to the emergency room because she said, I don't have anybody to take me. My friends are out of town. And I was like, well, somebody's going to take you. So, she don't want to take an ambulance. So, it's one of those things. I think, finding transportation can be hard and supportive care can be hard. So, the other thing we could do is set up home care, for some of these patients, looking for patient support funds. There are some others like breast cancer funds where they provide support for some of these patients and also provide like, people who drive them to appointments and things like that. We have, there's now a number of groups where we support some of them and have, worked with them as well. And that I think is a great resource. So, working with social work to look at some of the resources that are available for patients and patients who have breast cancer specifically is really worthwhile. But here we really want a fast response. So, we want to really use our resources and get the best treatment for our patient.
Yeah. And social work is definitely very key in all of this.
Absolutely. So we'll talk more about some of the side effects we look out for at the end of this section. We're going to talk about the data with ADCs and HR positive, HER2 negative disease. The first phase 3 trial that was reported was TROPiCS-02, where patients who'd received at least 2, but not more than 4 lines of chemo for metastatic disease, a CDK4/6 inhibitor, and at least 1 endocrine therapy were randomized to receive sacituzumab or treatment of physician choice. Again, the usual suspects, CAPE, vinorelbine, gemcitabine, or eribulin. And the primary endpoint was progression-free survival by blinded independent central review. This patient population kind of surprised us in that the majority had visceral metastases. So, median of 3 lines of prior chemotherapy for metastatic disease. At that point, everyone has visceral metastases, apparently, and, almost 100% of the patients. Also, it's important to keep in mind that CDK4/6 inhibitors were required for these patients. So that's also an important factor to think about. Sacituzumab govitecan resulted in a significant improvement in progression-free and overall survival in our trial population, with a hazard ratio of 0.65 for PFS and a hazard ratio of 0.79 for overall survival, both statistically significant. And when we looked at different time points, what we saw was 3 times as many patients were free from progression at 1 year who received SACI versus those who received treatment of physician choice. And if you looked at overall survival at 12 months, the difference was at over 13%. So really, I think, significant difference for patients in terms of how many patients were surviving at specific time points. Really important. One of the things we did see was a big fall off early on because these patients had received a lot of prior treatment. So you can see here that about 30% of the patients had progression at the first scan, which again impacts the difference in the medians, as we talked about a little bit earlier. We looked at a subgroup analysis, and basically the number of patients that did not have visceral metastases was 26. So almost everybody had visceral mets. So it's not a big enough population to really look at. So everybody otherwise benefited. We looked at CDK4/6 inhibitor duration also. And again, this is difficult because CDK4/6 inhibitors were just beginning to be used in the first line setting when this trial was starting. So we're not really able to assess that difference well just because of time points. But essentially, everybody seemed to benefit from of the different groups of patients, age, previous chemotherapy regimens, how long they had endocrine therapy, and then TROP2 expression as well, whether it was high or low at the bottom of this table. And then we looked, of course, at the treatment-related adverse events, and this is an important area to evaluate in all subgroups. This is a patient population that's quite similar to ASCENT, even though they had HR-positive versus triple-negative disease, a lot of prior chemotherapy, and 98% visceral disease. Now, what you can see is neutropenia. If you just look at the grade 3 toxicity, neutropenia is common at 51%. And then if you looked at, and again, we required an ANC of that these patients had to have 1.5 to go on to new cycles. And then diarrhea, 9% of patients had grade 3 diarrhea. So these are really still the two most common toxicities in this population as well. Alopecia, very common with sacituzumab govitecan. And I think the rates are low at 46% because some people went into the treatment without hair, because otherwise we really do see alopecia in patients who get sacituzumab. And we'll talk about that more as well. You can see that the nausea was all low grade. We're learning better how to prevent that, just quite mild, and otherwise there's no specific toxicities to note here. So the PRIME study looked at preventing these common toxicities from sacituzumab govitecan, specifically neutropenia and diarrhea, conducted by our colleagues in Spain. And this data was updated at ASCO 2024. Sarah, tell us about the PRIME study.
So in this trial, they took patients that were on sacituzumab govitecan, and they put them for the first 2 cycles on preventive therapies for both neutropenia and diarrhea. So for the neutropenia, they gave them filgrastim for 2 days after each dose of the sacituzumab govitecan. So for both after the day 1 and the day 8. And then for diarrhea, they had them take loperamide at home, and they'd have them take 2 milligrams twice a day for days 2, 3, and 4, and as well as 9, 10, and 11. So they did that for 2 cycles, and what they found was that patients had less diarrhea and less neutropenia. So the patients' neutropenia of any grade went from somewhere 65 to 70% down to 30%, which is great. Their grade 3 in grade 4 were reduced from, for grade 4, 17% down to 4%. So really nice reduction there. For diarrhea reduced a little bit less so, from 60% to 30% for any grade, and 10% to 4% for grade 3 and 4. So the patients that were on this trial also had less discontinuation of sacituzumab govitecan, presumably because of this prophylaxis that they received. So thinking about that moving forward with patients is really important. Reducing the suffering that they go through is important. Keeping them on treatments is always ideal.
No, that's a great summary, and I was really interested to see this. I think it's quite nice, and the growth factors I think are really important. I think the loperamide is something that we might give, and start out with it, and then sort of back off if people get constipated, but because not everybody gets bad diarrhea, only 10% grade 3, but to drop it to 4%, I thought that was pretty impressive, and have the rate of treatment interruptions also really great to see. So very nice data. We also saw some data at ASCO 2024 of SACI-IO, HR positive. There's also a triple negative arm that's still accruing, but this was a phase 2 randomized trial organized out of Dana-Farber, multi-center, 110 patients with HR positive disease, and they could have received 0 or 1 chemotherapy lines for metastatic disease, randomized to SACI versus SACI and Pembro. And they started out wanting people to have PD-L1 positive disease, but the incidence was low. So then they dropped that requirement and just made it a secondary endpoint, which maybe wasn't the best approach. I'll show you this data now because I think it did impact the outcome. So here's the overall population. This is really small. There were 52 patients in each arm. So really small number of patients with very heterogeneous disease and 0 to 1 line of prior chemo. You can see that the progression-free survival is almost identical. There's a numeric difference going from 6 to 8 months, but that's the median. It's hard because the numbers are too small to make that a difference, and there's an identical number of PFS events in the 2 arms. And then overall survival, of course, really immature for these patients, but you haven't gotten the outside 95% confidence interval, but even so, really suggests that there's no difference here with 15 and 20 events. And then looking at the PD-L1 positive status, the problem is the numbers are small, right? Because there weren't that many patients who had PD-L1 positive disease, 16 in the Pembro arm and 24 in the SACI arm, looking at the PD-L1 positive group. Here you can see that there's a suggestion of a difference, right? Going from 6.7 months to 11 months. Now, numbers are not great, tiny numbers, but suggestive that potentially PD-L1 positive disease could benefit from this combination in patients with HR positive, HER2 negative metastatic breast cancer. If you look at the patients who were PD-L1 negative, they had no benefit from the addition of Pembro. And the median PFS is shorter than what we've seen in other studies as well. So it's not clear exactly why that is in this patient population. Overall survival, no real difference, and very early in the data. And the safety was identical to what we would have expected from the previous trials. There were no new safety signals at all. Now, there's, as I mentioned, a new TROP2 ADC on the block, datopotamab deruxtecan, or Dato-DXd. We participated in TROPION-Breast01, a randomized phase 3 trial evaluating Dato-DXd versus treatment of physician choice in patients with HR-positive metastatic breast cancer. They had to have received at least 1 or 2 lines of endocrine therapy. They had endocrine-resistant disease, and they did not have to have received a CDK4/6 inhibitor, but it was a stratification. They couldn't have received more than 2 lines of prior chemotherapy, and the median number of lines of chemotherapy for patients on TROPION-Breast01 was 1. So it's essentially a group of patients treated in the second-line setting. 700 patients were randomized to get Dato-DXd every 3 weeks versus investigator choice chemo, which is exactly the same as we've seen in every other study in the later line setting: eribulin, vinorelbine, CAPE, or gemcitabine. And the primary endpoints are dual: PFS by blinded independent central review and overall survival. So they don't have the overall survival data yet, but progression-free survival by blinded independent central review was improved, and this was statistically significant benefit, going from 4.9 to 6.9 months at a hazard ratio of 0.63, statistically significant, and at the various time points also impressive PFS data, similar to what we saw with SG in the Tropion trial. Although it's important to keep in mind the median number of lines of chemo at Tropion was 3. Here it's 1. So interesting, because it's a relatively similar PFS, and maybe just what we see from these first 2 TROP2 ADCs. When they looked at it by investigator assessment, the numbers were almost identical. Response rate was also improved, as you can see here, the response rate going from about 23 to 36% in the entire population, and very low rate of CR, 0.5%, but only seen in the Dato-DXd arm. Overall survival is just too early, so we can't see that there's a trend, but we need to wait to see what happens with that. And also, we know that there'll be crossover to SG, so it's just hard to know. In terms of toxicity, SG has a different profile from Dato-DXd, which is interesting. So we talked about SG being neutropenia and diarrhea. Here, we don't see much neutropenia, so the any grade rate is only 11%, with only 1% for patients having grade 3 or greater. You do see some eye toxicity with dry eye, but it's only 22%, and very rare to see grade 3 or greater. An adverse event of special interest is mucositis stomatitis, and there we see about 50% of patients, but some of this has to do with the terms that you include. So we see in our I-SPY neoadjuvant trial, we've seen stomatitis rates up into the 75% or so range. Grade 3, 6% here. I think that's probably pretty similar to what we've seen as well. But we use all the terms that mean mouth pain in order to assess the stomatitis. And sometimes in these trials, they pre-specified they can only use certain terms. There were 3 patients who had adjudicated drug-related interstitial lung disease. And, as you can see, there was only 1 patient that had grade 3 ILD, and there was 0 mortality. So even though it's the same toxin, deruxtecan, as TDXT, we're just not seeing the same kind of ILD. And my guess is that's because of the HER2 receptors on the lung cells, and you're just not seeing the same delivery of drug to the lung when you're using these TROP2 ADCs. Alopecia, a little bit hard to assess. Some people don't lose all their hair, but most people lose some hair. And additional safety assessments look at the breakdown of grade 3 and lower stomatitis, mucositis, shown on the left, ocular surface events, mainly low grade, and ILD, as you can see. It breaks it down by the actual grade, and you can see that 9 out of the 12 patients had grade 1 or 2 ILD. Only 3 had grade 3 or greater. Then we also looked at the median time to onset in this presentation that Komal Javeri gave at ESMO Breast 2024. Stomatized mucositis early, so median time to onset is 3 weeks. But eye events take longer, so that's about 2 months, right? 65 days. So you're seeing it when people have already gotten 2 cycles. And then the ILD, the median time to onset was around 3 cycles, so it's a later event. And it took about a month to resolve in terms of median time to resolution, 28 days. Now, one of the things that was curious, I thought, in this reporting when we looked at it was the median time to resolution of stomatitis. And this just talks about resolution completely, but, we'll talk about later, what we're using as the treatment for stomatitis and how we can see rapid resolution, but maybe persistence of sores, even though they don't hurt. So grade 1 might hang around for a long time, but we see it hang around for months in patients, but didn't affect their eating and it didn't hurt. It was just something we saw visually. So really interesting. There are a number of trials looking at TROP2-targeted ADCs in metastatic disease. The TROFUSE trial looking at sacituzumab terumotecan, and the sacituzumab govitecan ASCENT-07 trial. The TROFUSE trial is the newest trial to open looking at a TROP2 ADC, and again, in the first-line setting. The other interesting thing is that in some of these trials, for example, the TROFUSE trial with sacituzumab terumotecan called SAC-TMT, they're actually looking at a checkpoint inhibitor as well, pembrolizumab in combination, to see whether or not that's any better in the HR-positive population in the first-line setting. So a lot of interesting data to follow as we go along with these trials that are currently accruing. So let's consider another case. Sarah, tell us about Anna.
Okay, so Anna's a 63-year-old woman with a history of invasive carcinoma of the breast. It's T2N2 grade 3, hormone positive, HER2 negative. She receives adjuvant chemotherapy. She gets radiation. Then she's on adjuvant AI for 4 years before she discontinues it because of side effects. 7 months later, she develops right hip pain. Imaging reveals lytic bone lesion. Staging scans reveal liver metastases and bone metastases involving spine, ribs, and hip. A biopsy is done of the liver. It shows, again, hormone positive, HER2 negative breast cancer. And at that time, she also has germline testing, and she's BRCA1 and 2 negative. She receives her therapy with fulvestrant and CDK4/6 inhibitor. She responds to it for over 2 years, and then she develops asymptomatic progression in bone. There's also a 1.5 centimeter new liver lesion. She has ctDNA testing that reveals an ESR1 mutation. She receives elacestrant next. She then progresses again. She receives capecitabine next. She progresses then again. And we're here now getting another liver biopsy. It's still hormone positive and HER2 negative. And just of note, the IHC is 0. So, Dr. Rugo, what do you think you would be giving this patient next?
Yeah, I mean, I think that this is a interesting case and always requires discussion with the patient. We would normally give sacituzumab govitecan in setting with the IHC of 0, second-line setting, and it's a really perfect setting to use a drug, which is better than our standard chemotherapy. I think that, the question that comes up after ASCO 2024, when we saw the intriguing data from Destiny Breast 06, where patients received trastuzumab deruxtecan as first-line chemotherapy versus treatment of physician choice, and most patients had the endocrine therapy, CDK4/6 inhibitor, et cetera, is interesting. These patients, in the first-line setting, 7% of them had visceral disease. Only 3% were bone only. This patient, has had a mostly bone and a few liver metastases, but not much. I think it's a tough situation. And the thing is that DESTINY-Breast04 included only HER2 low disease, so 1+ and 2+ without gene amplification. But DESTINY-Breast06 included patients who had HER2 ultra low disease. So in this case, you might want to call your pathologist and see if there's some expression of HER2, because your question is really going to be which ADC to give. And I think this is an evolving area. We don't have regulatory approval for TDXD for patients with HER2 low disease. So as of today, my choice would be sacituzumab govitecan in this setting. And of course, we only know about the ultra low disease in the first line setting from DESTINY-Breast06, because that's where it was studied. So here I would give sacituzumab. I would talk to the patient about hair loss coming in, day 1 and day 8 every 3 weeks. And then the toxicities as well in terms of the neutropenia and diarrhea, how to manage the nausea. And we give these patients, of course, as you know, a lot of prophylactic therapy as well as rescue therapy, and then recommend that they take medication with olanzapine the first few days. But we'll talk about that in a little bit. I think it's really interesting to think about the strategies that we could use to prevent sacituzumab-related adverse events in order to optimize patient access to care and benefit from treatment. Sarah, tell us about, what do you do when you educate patients about the adverse events? And then we'll talk a little bit more about how you manage them as well.
So I try to go over the most common side effects with them, so that they don't sort of get lost in the weeds if they read something on the internet about the potential side effects, because there's a long list. So the side effects that were present in more than 25% of patients in the trials were there was hematologic toxicity with low red blood cells and white blood cells. I tell them that we're going to check their counts every cycle before they get treatment to make sure that it's adequate enough. And then I also talk to them about the GI side effects, the nausea, the vomiting, the diarrhea, the abdominal pain that can happen, but tell them that we're going to be able to give them treatments to treat that and prevent that potentially. In addition, I tell them about the alopecia. This is their first chemotherapy that could cause hair loss. So that's a big thing to be discussing with them. Finally, I let them know that they can also have abnormalities in their chemistry panel and creatinine as well. So the things that I tell them that I need to know about in between visits that they can't just wait till their next visit to tell me about are symptoms of fevers, chills, cough, any type of infection that could be happening, like burning with urination, because if they're neutropenic, that could be really a problem. So they need to call in. Patients that have diarrhea from treatment, I need to know if they're having more than 3 loose or watery stools in a day. I need to know, of course, if it's black or bloody. I need to know that it's under control within 24 hours. I'm telling them to take loperamide, making sure that they have it at home before they get their first dose of chemo that day. They have to have it at home. And if they are having so much diarrhea that they're feeling lightheaded or dehydrated, I need to make sure that they're also replacing their fluids while this is happening. Hypersensitivity reactions can happen during the infusion or within 24 hours after the infusion. At our center, we give the first infusion a lot slower. We have a bunch of pre-meds. We'll talk a little bit more about that later, but I need them to let me know if they're having, the obvious signs: swelling in the face, lips, tongue, hives, skin rash, fever, difficulty breathing, hypotension, chills, shaking. They should call in right away. And then for nausea and vomiting, I need to know that it's controlled with our pre-medications and that they have medications before they get that first dose, at least 2 or 3 of them at home that they can take at first sign, because it's really better to be on top of it than to wait too long, because you can't keep it down. So those are the main things.
I think that's really helpful, actually, to know about, and I think that education is really important. So in this patient, she did get recommended to get sacituzumab govitecan, but then on cycle 2, day 1, she was, felt fine, came in, had an ANC of 800. Usually it's something like 820 or something. But now, what are you going to do with her? What's your plan now?
So we don't give treatment if their ANC is less than 1,000 or their neutrophil count is less than 1,000. So we would hold treatment that day. But I would, and what we do in most centers is we give them some filgrastim to increase their white blood cells. And then we'll bring them back 1 or 2 days later, at least 24 hours after that injection, to receive treatment. So we try not to delay them as much as we can. When it happens, and in that situation, I would consider giving the filgrastim preventively in the future so that I can prevent more dose delays. So it's the day 1 of cycle 2. I'd be giving it before that, bringing her back the next day, giving her treatment, maybe not giving her another dose right after that treatment the next day, but then when she comes back for day 8, then I would plan to give her the injection 2 days later, probably. And I would probably do that going forward. So our goal is to have patients be able to get the highest dose of sacituzumab govitecan and the least amount of delays, of course. In some centers, they don't do this and they just wait till the neutrophils approved, so they don't give the GCSF, but we always do. If a patient's having ongoing issues with neutropenia, regardless of giving them more than 1 dose of the filgrastim, you're giving them 2 or 3 days of it, maybe then you would start considering the dose reduction. But usually we can really prevent this using the filgrastim. And then there's always the possibility after day 8 of giving them pegfilgrastim, because that will last 2 weeks. That's always helpful and can be really prevent that 3rd week from having issues. If a patient has a fever and they're neutropenic and you've given them your GCSF, then that would be another situation where you would consider dose reducing the sacituzumab. What were you going to say, Dr. Rigo?
No, I think I was just going to say, what would you do with febrile neutropenia? But you said it. But I think I like the pegfilgrastim in people who need more growth factor support, and then you don't even have to give one after day 1 therapy, which is great. I mean, people we've treated have just done pegfilgrastim, and I think we've also seen that as we've treated patients earlier in the metastatic setting, so not so far out, we see neutropenia that starts later in the course of treatment. It's not like with the first cycle like it used to be. We're really seeing patients, if they've just gotten capecitabine or they haven't gotten chemo in the metastatic setting, we see the neutropenia much later. In general, not always, but for many patients. And I like your approach. I think it works really well. And then you're not having these patients who are neutropenic for a week, which is really not great for patients. And the other thing is, we educate our colleagues about is that if a patient's having diarrhea and they're neutropenic, even if you're somebody who doesn't give growth factors in the metastatic setting for neutropenia, that's uncomplicated, that's complicated. So if you're neutropenic, you have diarrhea, you can have tophitis and various things if you leave them neutropenic. So you really do have to give growth factors in that setting. So you don't want to stay your hand. What makes you dose reduce? Just to restate maybe what you dose reduce for.
So I would dose reduce if, despite getting GCSF and having neutropenia along with a fever, I would consider dose reducing. I would also dose reduce if I'm having to give, more than 3 days of the GCSF, like filgrastim, and I'm just not able to get their white blood cells up by day 8, for instance. So I would consider those 2 incidences when it comes to neutropenia. Of course, we're going to talk about diarrhea next, but. And then as far as dose reduction goes, 25% is the first dose level reduction, so 7.5 milligrams per kilogram. And then 50% dose reduction is 5 milligrams per kilogram. It's the second dose level. And after that, you wouldn't treat anymore.
Right. I mean, I think that's a great plan. And, I do think, maybe some people would use 2 doses of growth factor and then they would dose reduce if they didn't control it 2. But of course, we can use pegfilgrastim too. So I think 2 or 3 doses, pegfilgrastim, still having adverse events. So the patient manages her neutropenia with growth factors under your direction, but then she gets grade 2 diarrhea a little bit late, since most of the diarrhea in our trials occurred within the first cycle for people who are going to get higher grade diarrhea. But she has grade 2 now. So now the question is, how do you really manage this diarrhea and educate the patients as well?
So hopefully this patient already has loperamide at home and she's taking that if it's happening at home and if she's telling you about it when she comes back for cycle 2, day 1, or cycle 3, day 1. But there's two types of diarrhea that can occur with sacituzumab govitecan. One is acute and the other is delayed. So acute occurs during the infusion or shortly after. We give atropine IV. You can give 0.2 milligrams IV every 15 minutes for 2 doses if it occurs during the infusion or if it occurs in the setting. And then you can also continue to give them more doses for a total of 1 milligram. You could also, in the future, consider giving atropine before the infusions, although some people don't believe that that works. You just wait for the actual symptom to occur. It could be cramping and diarrhea. So cramping is also a reason to be giving the atropine, just to be clear. If a patient has delayed onset diarrhea, it's usually like 3 to 4 days after. It can last for 4 to 5 days. You're having them take loperamide just the way it says on the over-the-counter box, which is 2 tablets or 4 milligrams at the first episode and 2 with every subsequent loose stool or 1 tablet, with a max of 8 tablets a day or 16 milligrams. So I just remind patients, it says on the box, you can only have 4 milligrams, but you can actually have, you can only have 4 tablets, but you can actually have 8 tablets. I also talk to them about diet, make sure that they're reducing dairy intake, avoiding spicy foods, avoiding raw vegetables, because those can really make the diarrhea worse. So if the diarrhea resolves, then you're good. If it keeps on happening, you can have them take the loperamide sort of scheduled every 2 hours. You can consider things like Lamodal or octreotide sub-Q. I've gotten that approved for patients. I have a patient right now, Dr. Rugo and I have a patient together who gets octreotide as a pre-medication because she has so much diarrhea. That patient also has an issue with how she metabolizes SN38. So she has required a dose reduction because of diarrhea. For patients with severe diarrhea, more than grade 3, so just to clarify, that's more than 7 episodes in a 24-hour period, you can consider hospital admission, make sure that they're getting IV hydration because they're losing a lot of fluid. Really think about that octreotide and consider antibiotic therapy and stool testing, of course.
Yeah, I think that's really important. And it's interesting that the octreotide, which our APP suggested for this patient who's a poor metabolizer by UGT1A1 testing, was so effective for her, which is really great. So she was able to stay on therapy, and she's a patient who got treatment in the closer to first line setting because she has terrible resistant disease, and she has had a fabulous and long response, which is really nice. Unfortunately, these patients also develop other metastases over time, and she recently developed brain metastases, but she had a long duration of response without other options. We do sometimes see other non-neutropenic toxicity, although I have to say we generally don't because we're good at preventing. I mean, we use a lot of the drug. We just haven't seen any. But how would you manage this severe non-neutropenic toxicity?
So if it's grade 4, grade 3 or 4, you're not getting it under control with, the array of things that you're doing. So just to be clear, so for a grade 3 or 4 non-hematologic toxicity that you're not getting under control with your pre-medications or supportive medications, you would want to consider dose reducing by 25%. This patient that we were just mentioning, she, despite octreotide, despite some of her loperamide and Lamodal, she just was not metabolizing it well. We did have to dose reduce her, but she didn't require a second dose reduction. So a 25% dose reduction would be the first dose level and then 50% for the second. And if you can't control it, then you would discontinue treatment. But generally, like Dr. Rugo said, we can.
So there are some other treatment-related adverse events that we can see with SG, hypersensitivity. We talked a little bit about nausea and vomiting. How do you manage these in the pre-medication and monitoring during infusion?
So for the pre-medication for hypersensitivity, we have the patients get dexamethasone, Benadryl, I think Pepcid's on there, but you can always add if it's not. You give that first infusion over a longer period of time, and then you observe them for about 30 minutes after the infusion is complete. Of course, you have all of your rescue meds, your hydrochlor, and your rescue medications nearby. I have not seen a lot of this hypersensitivity reactions because of our pre-medications and our slower rate for the first infusion, but I know that it happened in the trials. For nausea and vomiting, I always give at least dexamethasone, which I'm giving anyways for the hypersensitivity. A 5-HT3 inhibitor, such as palansitron, is always nice if you can get that. And then an NK1 receptor, like fosaprepitant, can be really helpful in preventing the nausea that could be happening. I really, usually that is enough. But for many patients that I'm a little bit worried about, maybe they're younger, maybe they've had issues with nausea in the past, I like to give olanzapine for the first 3 nights. Usually 1.25 to 2.5 milligrams is tolerated pretty well and can really help prevent the nausea. So if a patient, of course, has grade 3 nausea, you would hold treatment until you get under control and then resume. I also make sure patients have, the run-of-the-mill, like ondansetron, prochlorperazine, and lorazepam at home to take as needed.
Of course, absolutely. And of course, if you're using the ondansetron, maybe you have less diarrhea. But I think that triple drug pre-medication is really a great approach for these patients. You can always back off, but it's so much better not to have it up front. We know that hair loss is common with sacituzumab. What do you recommend these patients?
So I will recommend that they get a wig if they feel like they will need one, and better to have it match your hair and style. So do it before you lose your hair. We can give them a prescription for the wig, and they can often get that covered, which is nice because those wigs can be quite expensive. I tell them that if they before they lose their hair, to be very gentle with their hair, not to be washing their hair too often, to use a hairnet at night, to sleep with a satin pillowcase. They can also protect their scalp from sun by using sunscreen and wearing hats, or a very gentle hat around their head. We do have cooling caps that we can use at many institutions. We don't know how well they work for this medication, but I still have many patients that use them for this treatment.
Yeah, I think we've had a few patients who've kept their hair with cold caps. We have to go back and look at it and see if we can collect some data, seeing what we can do, because it, is a drug that's given day 1 and day 8, but these drugs have long half-lives. But I don't discourage patients from using it. And I think when they do lose their hair, you just want to, the idea is you could get sunburned on your scalp, which is such a surprise.
With the sacituzumab, I was very happy that my pleural effusion resolved very quickly. That was, I guess, really kind of dragging down my quality of life. I think the side effects for me have been really manageable. I feel like I can continue living mostly a normal life, taking care of my 5 children, and spending time with my husband and family. I'm able to travel, exercise, hike, and remain active after the pleural effusion resolved. My blood counts have been good enough to receive treatment on each scheduled day, that day 1 and day 8. And as far as scans showed, my first scan after beginning sacituzumab, my tumor in my lung had decreased. My second scan showed that it was stable, and my third scan will be next week. So I feel like as a whole, the side effects have been very manageable, and also the drug has helped me to regain my quality of life.
Now, with Dato-DXd, there's a really low rate of ILD compared to TDXd, and there was no mortality in Tropion, which is great. It was all mostly low grade. So we could talk a little bit about managing ILD in those patients, but it's clearly a rare event. And then eye toxicity is definitely something we see with Dato-DXd, again, mostly low grade, but it's worthwhile talking about. And then stomatitis mucositis does occur in more than 50% of patients. So, I think that this will be something that we definitely want to talk about. And then, some of our preventive strategies we're using at UCSF. So what do you do when you're screening patients for ILD pneumonitis?
So one is it's similar to trastuzumab deruxtecan, and I'm sure everyone is very familiar with how to manage that at this point. You make sure that the patients know what to report and when. So dry cough, shortness of breath, we need to know about between visits, and then we always ask at the visits. And if they do say that they're having any of those symptoms, then we, regardless of what else the patient tells you they think it could be from, because they always tell you, oh, I think I have allergies or something else is going on. Regardless, you always just rule out the ILD. So again, for monitoring, other than asking them about symptoms, I often will be getting scans a little bit more often in these patients rather than waiting the full 12 weeks before you get your next set of scans, maybe doing at 9 weeks or 6 weeks for a patient that you are worried about. Maybe they have had lung toxicity before. Maybe there's something about them that makes you nervous. So doing it a little bit more often, especially in the beginning, it's fine. Again, this toxicity was not very common, and it did appear at 3 months or third or fourth cycle. So just be wary of the timing of it. If somebody's coming in with a cough after their first dose and it's productive, maybe don't worry about it as much, rule it out. But if it's happening in that window a few months later, you really should just get a CT of the chest. So a high resolution computed tomography is really the best way to determine if somebody's having ILD and pneumonitis.
So I think, this is kind of interesting because it is low risk. So I don't know that we need to do our CT scans quite as frequently as we do with TDXT, but we do generally tend to get a scan early. I mean, the drug isn't available to us yet. So when it is available, the question is how frequently will we do our CTs? And I'm guessing it'll be 9 to 12 weeks. I think the key thing that for my take-home message is really that if you have grade 1 ILD, because it's deruxtecan, the recommendation is still to hold drug and wait until improvement of the radiograph. And if you have symptomatic ILD, you should discontinue drug. So we don't want to see any mortality. So I think that we want to be really careful. We don't do, pharmacokinetic analyses or standard pulmonary function tests in these patients. But obviously, if somebody has symptoms, you want to check their oxygen saturation, and then you want to make sure that you've worked with a pulmonologist to rule out any other kind of, causes. Does a patient have something? They've been surreptitiously taking steroids and have PJP, or they, have progression of their cancer. For example, one patient whose doctor thought she had immune ILD, immune pneumonitis. I had our pulmonologist biopsy her lung, and it was all cancer infiltrating. So lymphangitic spread. So I think we do want to be cognizant of that, but I have a low threshold to give steroids to start with. And speaking of steroids, how do you manage mucositis stomatitis?
So it was so common in the trials with Dato-DXd that we at our institution start patients right off the bat. The day that they get their first dose of Dato-DXd, they're getting a dexamethasone oral solution that they swish, hold for 1 to 2 minutes, and then spit out. So remind them to spit it out and not swallow it, because that's a lot of steroid. And they do that 4 times a day. And they do it right off the bat in the beginning. We also have them after they eat. I'll have them do a rinse with salt water, baking soda as a way to clean their mouth, make sure they're brushing their teeth with fluoride-containing toothpaste. I make sure that if they're having mouth dryness, that they're, using something like a Biotine spray to keep the moisture up in their mouth. If they do develop these mouth sores despite the prophylaxis with the dexamethasone mouthwash, I will consider things like cryotherapy, having them hold ice chips in their mouth during the infusion. I would also make sure that I tie in dentistry or their oral surgeon or dermatologist if it's something that I'm not quite getting under control. I really have not had personal experience with patients' oral sores getting so out of control. Usually it's like a grade 1 or 2. They can see the oral sore, they can't feel it, or they can see it and they can kind of feel it, but it's not preventing them from eating. So if it gets to the point where it's preventing them from eating, that's when you need to sort of up the ante and make sure that you have people helping you.
Yeah, I think that's interesting. I mean, I like the steroid mouthwash a lot, and we found it worked well. But in patients who still got, there are clearly patients who will still get bad stomatitis, even though a small number, they use the steroid mouthwash. So the dose reduction, I think, and delay till recovery and then dose reduction is a key management strategy. For eye toxicity, it's an interesting area. I don't think we need to go into in great detail. Again, we don't have data available yet. It's generally low grade. We tell people to use artificial tears 4 times daily for prevention and, avoid the use of contact lenses. But, I think it's really hard for people to do that all the time. We work with our ophthalmologists and we have ways of managing it if patients do have dry eyes, sometimes using the more viscous tears and also using ointment at night helps, putting on an eye mask at night so that you don't open your eyes helps as well. If they do get dry eyes, that's an important time to stop using the contacts. But again, this is working with ophthalmologists really to try and better manage these patients. So, I think we've had a great conversation about TROP2 ADCs. We've focused on how to use, the existing data from randomized phase 3 trials, how we would make choices for specific patients and patient situations for both triple negative and HR positive HER2 negative disease. And then we've had a great conversation about toxicity management. Sarah, I'm interested in your key takeaways from our conversation as well, and really appreciate your thoughts and comments throughout our discussion.
Thanks. I just think it's important to really understand how to manage these toxicities from an NP point of view. That's sort of my bread and butter. And I think keeping patients on treatments longer and at the highest dose possible is always what we want. So really, really paying attention to the details, making sure that you get a good history from the patient and that you give them very concrete therapy options is very helpful. So hopefully this will help you all treat your patients with sacituzumab govitecan.
Thanks so much. And thanks for talking with me today. And thanks to PeerView Press for hosting this program.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Living Beyond Breast Cancer. This activity is supported by an educational grant from Gilead Sciences Incorporated. To access all materials for this activity, visit peerview.com/TSZ860.